afternoon, everyone, and welcome to today's edition of Black Health Trust. We are so happy that you chose to spend some time with us this afternoon, and we are very excited about our guest today and the opportunity for us to discuss something that is very important and pertinent to our children in our community, and it is not talked about nearly enough. So without further ado, I'll turn it over to our founder, Dr. Randall Maxey.
Thank you, Dr. Barbara Neighbor-Stevens. And I'm Randall Maxey, an internist nephrologist who practices on the West Coast. I want to do something just a little bit different. Every now and then, I want to remind people who our co-moderators are. I'd like each co-moderator, starting with Dr. Hines, then Dr. Walks, ended up with Dr. Stevens, who's going to introduce our guest, to just say 30 seconds about who you are and what you do. Dr. Hines?
Yes, so hello, everyone. My name is Jocelyn Hines. I am a board-certified family physician. I practiced primarily in federally qualified health centers in the Baltimore City area, but I spent a little bit of time traveling all over. And currently, I am the Chief Medical Officer for an in-home healthcare company.
Thank you.
Good afternoon, everyone. My name is Ivan Walks. I'm a psychiatrist. I have practiced in the public sector and the private sector, formerly the Chief Health Officer for Washington, D.C., and currently practicing psychiatry in the area of Washington, D.C. and Maryland.
And I am Barbara Neighbor-Stevens. I am a board certified pediatrician, but I have been blessed with the opportunity to work in various areas, including academia, research, public, government affairs, and currently at private practice, and currently as a medical executive with a Medicaid managed care company.
Thank you, Dr. Neighbor-Stevens. We appreciate you inviting our distinguished guests today.
It is my pleasure to introduce to those and present to some my friend, Dr. Theodora Pinnock, who is an outstanding pediatrician in general pediatrics, but her specialty is developmental pediatrics. She is passionate about pediatrics and the care of children. She is a Texan and received her early training at Rice and received her Doctor of Medicine from Texas Southwestern Medical School in Dallas. She has found her way to Nashville, Tennessee, where she has been for several years now, and has served in many roles. She has been an employee in the Tennessee government. She has been assistant professor at Vanderbilt. She is currently, and I'm very proud to say this, she is currently the Associate Dean of Student Affairs and Admissions at Meharry Medical College, where she also oversees the program in developmental pediatrics. And she is going to talk with us today about the color of autism. And without further ado, I turn it over to Dr. Theodora Pinnock.
Thank you so much, Dr. Neighbor-Stevens, my very, very good friend, y'all. I have my very good friend and my boss, Dr. Exelana Bean, on the line today. So just know I'm going to walk a straight line today. You don't have to worry about it. I'm going to be on the straight and narrow, real straight. But anyway, I just appreciate the opportunity to come and talk to you, as Barbara said, about something that is definitely on my heart, which is trying to help kids, in particular kids of color, Black kids on the spectrum. And I am very glad that you offered this opportunity to me. I hate lectures, y'all. So if you have questions as we go along, please stop me. You don't have to wait till the very end. Please raise your hand. And Dr. Neighbor Stevens, would you keep an eye on the either the chat or folks raising their hands so I can keep my head and my eyes on the things I'm supposed to do?
We got you. You got
Okay,
it.
thank you. Thank you so much. I'm going to share my screen with you. I think, let's try that again. Okay, here it is. Can everyone see that?
Yes.
Yes.
I gave Dr. Neighbor Stevens the title, The Color of Autism, but I didn't want to take away in anything from the organization, and I'll discuss that organization with you. So I switched the topic and said no ID for me in discussing racial disparities in autism. Okay. Simon assured me that he was going to help me. Good. There we go. We can advance the slides. The work I've been doing recently over the last 3 years has involved a colleague over at Vandy, Dr. Amy Whiteloff, who's a psychologist at the Triad Center at Vanderbilt, and that's the Treatment and Institute Research for Persons with Autism Spectrum Disorder. Also, Dr. Zach Warren, who is a longtime national and international autism researcher, have been my good friends and partners in crime in trying to get some of this work out and hopefully changing the face of what we're currently seeing. I have practiced now. I have had the good fortune to be at Meharry since 2013. And so I've seen quite a bit and quite a change in my practice. When I got to Meharry in 2013, the average age of diagnosis for children and young folks that came to see me was about 14 years. I was diagnosing 14-year-olds, 18-year-olds, lots of kids that were already double digit for the first time, and they had been through a lot of just a bad time at school and not really thriving. And their most common misdiagnoses were ADHD, oppositional defiant disorder, explosive disruptive disorder. And my referral source was Centerstone, which is a behavioral health center here, Head Start, private practice, as well as my colleagues at Meharry. Some of the main problems that parents seemed to tell us was that they had difficulty finding resources, not only finding providers to identify, but getting the correct school assessment and services. And so one of the things that I had done in my time in Nashville was to start to go to school multidisciplinary meetings to advocate for my patients needing care. And I have continued that since I've been at Meharry. You know what happened in 2020? We had a pandemic, and I had to change the way I did things, because usually when I assessed the kid, did the testing, that was a 2.5 hour process. And it was no way at 2020 that I was going to stay in the room with someone for 2.5 hours, and vice versa. They shouldn't stay in the room with me. So we changed the way we did things. I still did the assessments in person, but I would give parents the results on Zoom, and I still do that. And now I would tell you the average age of diagnosis for me is 3 to 4 years. I'm just ecstatic. And over the last few months, I've seen anywhere from a 10-month-old, 18-month-old, 16-month-old. The youngest I've probably seen is 8 months. It's been refreshing because I could get these kids to early intervention. And instead of coming with those other misdiagnoses, these children are coming usually with delayed language as their diagnosis. And they're coming from my colleagues at Meharry, from a big medical group in Clarksville, and from the Federally Health Qualified Center, Matthew Walker here, as well as all over Kentucky and Alabama. But parents are still having the same problems. They have trouble finding resources that identify the kids as well as the appropriate school services. So one of the things that we noticed, my colleagues at Vandy and I, is that Black children in the US were having a problem being diagnosed. They were usually getting diagnosed an average of 3 years from their counterparts of any other race. Hispanic kids have had some difficulty too, but Black kids were certainly having problems. And Michael Constantino and his group in St. Louis did several studies pointing this out. And not only were they delayed in being identified, in his study in 2018, they found that most of these parents had to go through 6 professionals before they got the right diagnosis. And you and I know healthcare today, trying to find 6 professionals before you get to the right one is more than a challenge. Families were saying that professionals, for the most part, dismissed their concerns, and that they really felt that racial bias impeded the provider hearing what they said and what they told them. And Marlowe et al. Said Black families were traditionally underrepresented in the autism research, including screening methodologies, as well as culturally competent assessment tools. And then Dr. Brader and all sort of laid it on the line that it's more structural racism in how we approach the screening diagnosis. And I can tell you, I can walk in a room, I can see little kids spinning and flapping and doing things, and a teacher would tell me that that child had ADHD. And my question, and my students will tell you, I'll ask them this question: look and tell me or show me, when does ADHD cause repetitive movements? And so,
Can you
knowing
explain
that,
exactly what autism is, Doctor?
yes, I will gladly do that, Dr. Maxey. Autism is a problem in 2 areas. One area is communication and social interactions. It's an impairment. Most of the kids, as high as 60 to 80% in some studies, have delayed language. So they don't communicate well expressively, especially. Also, they might not communicate as well non-verbally. So these kids just don't ask for their needs, point out things, describe in particular social interactions, as well as their neurotypical peers, their peers that are developing normally. As well, There's social interactions, the eye contact, the going back and forth, the being able to say, look to them, and they look at what you're pointing to. Those, they have an impairment in that area as well. So that's one category. The second category is an impairment in repetitive behaviors. And that's some of what I've already described: flapping, rocking, head banging, hitting themselves, jumping up and down, flipping lights on and off, you name it. And restricted interests. These patients generally have fixations, I call it in the layman's term, just fixations on certain things to the exclusion of everything else. So those are kids that are considered on the spectrum. The DSM-5 came out in May of 2013, and we used to say things like autism, Asperger's syndrome, pervasive developmental disorder not otherwise specified, but we stopped saying those. And now with the DSM-5, we say autism spectrum disorder and a level of severity. The level of severity is based on the communication and social interaction skills. And level 1 is mild, that person can interact with you and go back and forth. Level 3 is severe. That person usually has lots of non-purposeful movements and behaviors and just cannot express themselves in a consistent way. So, any other questions?
Yes, and can you just speak a little bit about why there is misdiagnosis or overlap with, for example, ADHD? Like, where, to your point, right? You're going in these classrooms and people are saying, oh, they've got ADHD. Can you just speak a little bit about why people get the two kind of confused?
Well, I think we're finding that it has to do with sometimes with the color of their skin, because autism in a Black child looks the same as autism in any other race. It's sort of like Down syndrome, looks the same. So people are not spending enough time really looking. And that's what we found. We actually talked to parents. So this wasn't a guessing point. We actually talked to parents, and you can see the different folks that we came together, and we looked at 39 4 and 8-year-olds over in the Adam Network group of kids from Tennessee. And what we found is almost all the kids had some type of formal screening, and 68 of them failed the MCHAT at 18 months. So these kids even failed the MCHAT. So,
and the MCHAT is?
The MCHAT is the Modified Childhood Autism Toddler Scale. And it's a known screening tool that we've used for quite a while. The other side was parents usually didn't mention the word autism, only 8%, but sometimes the providers did. And both parents and providers were more likely to talk about and make referrals for speech and not the other aspects of autism. Speech language is a evidence-based way, but there's occupational therapy. There's also can be applied behavior analysis if the child requires that. And that provider concern was the primary referral driver. So if the provider had a concern about it, it got referred. If the provider did, for whatever reason, there was no referral. So You asked, ma'am, the reason for that. I didn't talk to specific providers, but there is just something different in the way, in particular, Black kids are looked at when they are being considered for the diagnosis. Did that answer your question?
Yes, thank you. And it also answered one of the questions in the chat that was referencing what testing is used to diagnose autism.
I
I
will
want to
go
push
ahead.
a little further. We may
Okay.
not have the data to support my suspicion, and I understand if you don't want to say what I would like for you to say, but do we have a quality problem in this country regarding the care our children are getting by non-Black child health providers?
Well, the research says we do, Doc. They say things like if you are a neonate and you have a white doctor, you are 2 to 3 more times likely to die and you're sick than if you have a Black doctor. And that has been borne out in several different studies, not just on the neonatal side. So I do think finding good, culturally competent care is very, very hard. And I can tell you, I know the numbers for developmental pediatricians. There are less than 1,000 of us practicing in the US now, and less than 100 look like me. So the odds that you will find a developmental and behavioral pediatrician of African American descent is not too good these days. So I think we're going to have to until we get more of us, or we're going to have to teach the other providers a better way of assessing kids. I think that's the only thing we can do because there's just not many of us out there. We also spoke to 8 mothers. We did a evening Zoom with 8 different moms, and they weren't just from Nashville. They were from all across the southeastern U.S., one from Georgia, one from Kentucky, a couple from Tennessee, and I think one from Arkansas. And their children were varying ages. And we asked, what could we do? Because they had, their kids had been diagnosed, but they had gone through lots of issues to get their children diagnosed. And they gave us some recommendations. They said we should build relationships with the support networks out there. They said we should develop a screener that considers cultural nuances in perception and language when discussing autism for parents. That we should establish a comprehensive program to educate parents. And I think that was very, very good advice. So we took it a step further. It's hard to know how we could be better without understanding what we're not doing well. So we decided to ask. And we received a grant from the Spark Foundation. We developed what was called a diagnostic experience survey. And we asked parents, it was 400 Black parents all across the country whose kids had been diagnosed. We asked when, we asked what was it like getting their children diagnosed. We asked, did they think racism played a part? And you can imagine, we got answers. It's really hard, again, to know how to be better without figuring out what we're not doing. Families talked about symptoms not being clearly associated with autism and when were their first concerns. And maybe we need to add those things like, little Johnny sits over in the corner and just hums a lot. Or little Johnny knows every song on the radio and can repeat those words in the songs, but little Johnny can't talk. And so one of the things I've noted anecdotally, and this has been held up in research, is in particular, Black families tend to not say things about their children. Like my child has repetitive behaviors. They'll say, little Johnny sits in the corner and hums. And we just thought that was little Johnny. He's a little bit different than our other children and grandchildren. And many families said they just had not known what autism was. So that when they get screening, as you may or may not know, every child, according to the American Academy of Pediatrics, every child should have the MCHAT screening at 18 months and again at 24 or 30 months. So we need to talk to parents about what that screening is and what it's being used for. Can we incorporate direct teaching about the systemic bias that we see, especially for providers? And can we deliberately investigate race, ethnicity, and language as constructs that influence those critical clinical pathways that we see these children and families need to go? So we tested those 400, or we talked to those 400 families, and this information is found on the SPARK website. I will tell you some things that we saw, just so you will see that 95 out of that 400 had language delays. So you see the description there. You see things like sensory differences, atypical social interests, eating habits, eye contact, almost a regression. So all those things were some of the things that the parents described as the things they went and told the pediatrician. And anybody that's done the MCHAT, even the revised one, knows there's no questions on there about hand flapping, toe walking, really speech delay, sensory problems, some of the repetitive issues, the tantrums and the emotional lability that the kids had, or the picky eating. That's not on the MCHAT, even the revised one. So there's a problem in itself. We have a major screener that doesn't even ask some of the things that parents were seeing.
And why is that?
Well, that's a good question, Dr. Nabreth Stevens. You have to ask yourself, most of our screeners in this country were not based on a culturally diverse group of patients. They are just not. So the MCHAT follows suit. So we really need to change that. And parents were describing that there were some cultural differences, and there were even differences in how the family saw the kid. They might think something was wrong, but they didn't necessarily talk like the child had a disability. And that's okay if a parent doesn't describe that. Doesn't mean the kid does not have a disability, but you just have to be culturally competent and understand what parents were looking at. And one parent said they feel that the Black community is left behind in knowing about autism. And because of that, children are looked at differently. And they're usually, because of their tantrums or their sensory disorders or some of their responses, they are oftentimes diagnosed with bad behavior, socially emotional disturbance, intellectual disabilities, or that they can't be academically successful. And that's just a lie. If you give them the right resources, they most certainly can. But you have to give them the right resources. And I talk to my students. I say, you can't afford to call this kid ADHD. You just can't. Why? Even though the kid might have some ADHD symptoms. As a provider, which of you for ADHD, your first line would be speech language treatment or occupational therapy? And that's the first line of treatment for autism. So you can't miss it because you won't even be giving the child the right things. And some parents felt that the providers seemed to pass them off, and that their children misbehaving was a Black thing. And to add insult to injury, that they were just there trying to get funding from the government to help their kids. So, i.e., Social Security disability. And here it is, parents are going through 6 professionals to get their kids diagnosed. And ma'am, there's a quote that a parent said that the community struggles all the time with physicians and medical staff. And an understanding of our past when it comes to medical staff and healthcare, along with compassion, can go a long way. So I would tell you, we're trying to teach the next generation of physicians some of this information. And while they're at Meharry, we're making an effort to teach them some history. There's been a Meharry and a Howard for a long time, but there hasn't been organized medical organizations and agencies for Black physicians that long. So we have come a long way, but for all our children to be helped in the way they need to, we're going to have to go further.
So there's a question.
Okay.
Wanting, I guess, go back and review again what the screening test is, the
Okay.
MCHAT-R.
The AAP still says use the revised MCHAT. And for all kids, not just kids you suspect with autism or kids with delayed language, all kids at 18 and or 24 or 30 months. Because I remember I told you in that first group of 39, 68% had failed that. So you've got a kid that failed this screener. What do you do? So MCHAT is one. The CARS is more a diagnostic test. That's the Childhood Autism Rating Scale. And I use that quite a bit. It's the 2nd edition. And I use it's called the ADOS, the Autism Diagnostic Observation Schedule. I use those 2 as my diagnostic tests. But if you have a provider that has a failed screener, that provider is obligated to follow that child and to look. So those are the screeners mostly in the pediatric side. In our clinic, we use ages and stages for birth to 60 months. So you can see what a child is doing or not doing in language, in fine motor, in gross motor, in their cognitive or problem solving area, and in their social emotional. So those are some screeners. Take less than 5 minutes mostly for different ages, and you could easily determine. But I would just tell you, if the child fails the screener, don't ignore it. Don't ignore it, especially the screener for autism. Don't ignore it.
Are we
So-
sure the screeners are being given?
Well, it's funny you should say that, Dr. Stevens, because in Tennessee, we got in trouble. We weren't doing it. And we came under a class action lawsuit in the early 2000s that said that most providers weren't doing it. And if you say you do it, but you don't document your results, you didn't do it. So that's another good question. I think we arm parents with knowing if the kid goes to a well child visit, they should be getting some type of screener, and they should know the results of that screening. And if the child fails those results, ask that provider, what are we going to do next? How are we going to look at this? So that's a good question. In Tennessee, it wasn't being done, Doc. We had to undergo almost, I think it was 18 years of a lawsuit to get it done. So I suspect that's the way in other states too, but I won't say that.
So
I
how
will talk about Tennessee.
There's another question. So
Okay.
how does a parent go about making sure that their child is getting the appropriate test that they should get?
I would add, what screening test? If they go to a well child visit, they should be getting a screening test. That's what the AAP says. So ask, what screening test did they get and what were the results? And if they didn't get a screening test or someone won't tell you, then my feeling is you probably have the wrong provider. So if you take your child to someone for something specific and they don't do it, and you pay money for that, I wouldn't keep paying money for that. And so you can say to me, well, Dr. Pinnock, you just told me there are not that many of you across the country. I know that. But this is your money, and that's where parents have leverage. They're paying for the services. So they need to require the information.
There's
Did I-
another
Okay, go ahead.
There's another question in the chat. We were talking about the history, and the question is about the history of association with vaccinations and autism.
Absolutely.
Is that a
That's-
black thing?
Is that a what, Doc?
Is that really a black thing?
No, that probably is not. I have never considered murder, but that is one researcher that if I could have taken out, because of all the distrust and the misinformation that has led to so many kids getting sick and getting sick again. We are seeing polio and measles again. I barely saw that going through my residency, and that was doing infectious disease electives. So I'm saying that's not just a black thing. As a matter of fact, it was probably more a white thing, and we have bought that. Now, moms might not like their kids having 6 to 8 injections at one time, then spread them out. But some of these childhood illnesses have some very, very bad outcomes, and we can't afford for our children to have them. And if you're not going to vaccinate your kid, then keep your kids separated. That's the other side. Your kid doesn't have the right to be at the park and the zoo exposing everybody else, or at Disney World where some of the outbreaks have been. And that's my opinion. I told you my boss is on the phone, but that's my opinion. If you want to if you make that decision, then don't put somebody else's child at risk. So we have debunked the myth that autism is caused by vaccines. Do children have adverse vaccine reactions? Yes, yes, and yes. Is that the usual main cause, some cause of autism? No, no, and no. As a matter of fact, there are a couple of those childhood illnesses that you're more likely to get a kid with autism or intellectual disability just because of the infection. So let me just say it again. It's not. It was misinformation then. It's still misinformation. I know there have been celebrities. I know there have been websites. I know there have been advocacy groups, black and white. The answer is no. I do think you have the right as a parent to, if you don't want your kid to have lots of vaccines at one time, spread them out. But do your kids need the vaccines? I would tell you yes.
So the question, what causes autism then?
Oh, that's a great question. And y'all, if I knew the answer to this one, I might be able to retire early. We still don't know. Still, the most common genetic cause of autism is something called Fragile X, which is mainly in an affected male. The mom is the carrier for that gene, and that's the most common genetic cause. We have seen a just explosion of autism in families, and there's several studies that say if you have one kid on the spectrum, every subsequent birth is more at risk than the general public to have autism. And so there does seem to be something genetic probably, but we don't know the exact answer to that yet. As a matter of fact, I would tell you in my practice, I've seen a lot more chromosomal 16 deletion causing the autism than I have Fragile X. So, any
Are
other
there more
questions?
Black children with autism than white? Or is there any disparity?
No, the disparity is the other way, sir. It's more white children than Black and or Hispanic or indigenous children. But it used to be when they first started looking at the numbers, and in some places, there really is no difference. So that makes it even more suspect. If there is no difference in the incidence of autism in a community, then why aren't Black children getting identified at the same rate, or identified earlier, or given services earlier? So those are questions that we have to ask. Any other questions? I put this picture here because I want you to see some of Meharry's finest. This young lady is a 4th year, about ready to graduate. She came to Meharry going to be a developmental pediatrician because she had a mentor before she ever got into medical school that was a developmentalist. And she had brothers and people in the community that had disabilities, and she wanted to be able to help them. So,
That picture, excuse me.
You can't see the picture?
Yeah.
It's on the slide at the top.
Yeah. Her name is Yawende Dada. And Yawende asked the question, if you looked at race and ethnicity as a possible reason that your child or played those race and ethnicity played a part in your child's diagnosis, what do you say? And what she found was if your kid got diagnosed early, i.e. before 37 months, they were less likely. They only said 19% of the kids were race probably played a part. But look at that next number. If your kid was diagnosed later than 37 months, 40.88% thought race played a part. So we really now have the data. And you can see the early diagnosis group and the late diagnosis group to see what parents told us. These 400 parents told us about the role they thought race played. The parents said, listen to what we have to tell you. There's that quote again about struggling with staff. There's that information in general is not necessarily very public in our communities. And look at that one. Parents ask for an evaluation that use culturally relevant activities and toys. So I would tell you, my colleague Barbara just asked, were they even getting screening tools, let alone when a parent asks them, is this a culturally relevant or a culturally competent tool? Has it been normalized in populations of color? I dare say you're not going to get a positive answer to that. Here were some of the things that we came away with that we should do in relation to the information that was given to us by the parents. That we certainly have a lot to do on the research side. We have to share more with family groups, especially in the Black community. We need to brainstorm more for ways to educate our communities and our parents. And we're going to keep working across that Meharry and Vanderbilt relationship to try to get more information. So I put here some of the resources that you can look at. There is a group called the Black Empowerment in Autism, and that's run by Dr. Brian Boyd. He's a psychologist at UNC Chapel Hill. He was the interim director of the Frank Porter Graham Developmental Center, and that's Brian_Boyd at unc.edu. And there's my information, and Amy Whiteloff, my partner in crime. The reason I changed my title, there is a Black advocacy group called The Color of Autism. And I put the website there, as well as an Autism in Black. And so feel free to go to both of these. They are beginning to do more things. The Color of Autism has been around for at least 5 years now. Autism in Black, I think, started in 2022 or the end of 2021. So We have just a few more minutes. I don't know if Dr. Neighbor Stevens, I should turn it back over to you, or we can ask questions. I can answer questions.
We certainly want to invite questions from our audience. I'm going to ask Dr. Walks if he has any questions. And Dr. Maxey, I didn't mean to ignore you, but you've been floating questions to me. Did you have any more? And then after Dr. Maxey, then Dr. Walks.
Let's go with Dr. Walks.
Thank you, Dr. Neighbor Stevens. Dr. Pinnock, thank you so much for this presentation on this subject. My question is, so often we identify a challenge that a child has, and I'm wondering, when children of color are identified and get resources, can you just talk a little bit about the potential for these children to do well and to develop? Because we think about autism as one of those, oh my goodness, this kid has autism and it's just horrible. So can you talk a little bit about the potential for these children when they receive services?
Dr. Waltz, if I could make my students do something, I would make them screen every kid. Because if we get to these kids early in the first 3 years with this diagnosis and then with proper treatment, by the time some of them will be school age, they will not look very different from their normally developing peers. Some of them will still be a little odd, but they will express things better. They will do better in school. Early intervention works in Black kids like it does white kids. If we find these kids early, I tell my students, I want somebody to ask the mother, what was Dr. Pinnock smoking when she diagnosed your kid at age 6? That's what I want them to ask me. Because those kids can look so different. And let me tell you, Doc, my colleagues have, because it takes time to get in to see me, my colleagues have started sending kids with language delay to the speech and language therapist. You don't need me to tell you 3 or 4 months later that the kid has delayed speech. So we send them to the early intervention services, the speech language services, and 2 of my colleagues' children just recently, one had 6 months of speech, one had 4. I diagnosed them with delayed language. They had some oddities, but for the most part, what my colleague originally saw was gone.
Dr. Pinnock,
So
I want to add on to Dr. Walks. I have a friend who has a daughter who was diagnosed as Asperger's.
Asperger's.
She graduated from college with a 4.0 for the Peace Corps. She's now a professor somewhere in Ohio. Can you comment on this? She was diagnosed early, but is this not a test of your intelligence, is it?
No, sir. Most of the time, and that's the blessing for us now, Dr. Maxey. When I first graduated from residency in 1989, a lot of the kids had associated intellectual disability with their autism. But now, not so much. But let me tell you the travesty. More Black kids have intellectual disability associated with autism than any other race. So we don't have a choice. We have to get our kids diagnosed early. We have to get them to treatment early. It's hurting them. The providers can't keep making the mistake. We're doing kids harm. And the research now says that the reason there are more Black kids with intellectual disability is they get to treatment late. We can't do that. I'm sorry, y'all. I think you can see
Your
I'm on
path.
a mission. We can't keep allowing this to happen.
Dr. Pinnock, passion matters. Passion matters. Thank you. Dr. Maxey, Dr. Johnson has had her hand up and Dr. Lawson has his hand up.
Please recognize him.
Thank you. Thank you, Dr. Pinnock, for an excellent presentation. I do have a question because the challenge I see is older children with autism that are more severe and they fall through the cracks. So as they transition into adulthood, do you have general guidance? Because I know parents that are really, really struggling right now to find services for their adult child with autism who has still disabilities of, toilet control, disabilities of language, the whole spectrum, that's tends to be a little bit more severe. So do you have any general guidance? Thank you.
Oh, you're welcome. My general guidance is, at least in Tennessee, we have several organizations that also help adults with disabilities. One is the ARC. It used to be the Association of Retarded Citizens. We don't call it that, but the ARC of Middle Tennessee, because that's where we live. One is called Autism Tennessee here. They have a hotline and they have a whole plethora of adult services. That's for Tennessee. The national resource is Autism Speaks, and Autism Speaks has not always been culturally friendly or finding those resources. But if you would take my email and email me, I'll try to get you the resources in whatever area you're looking at. I think the Color of Autism does some at trying to help parents get connected to services. I don't know so much Autism in Black. I've had more input with the Color of Autism. So I didn't give you too many specific answers, but I'd love to try to help you find some in your area, because most of the governmental agencies are the same. They just have different names in different states.
Thank you. Is Dr. Lawson available?
Dr. Lawson? We can get him unmuted.
Yeah.
There we go.
Thank you very much for discussing and raising all the issues that's involved in autism. I've been involved with for a number of years, back in the old days in the 90s when I was in Tennessee and was director of mental health, mental retardation. At that time, autism was lumped under mental retardation. And first thing we discovered was that they were saying that autism didn't exist in Black folks. So it was a big battle to try to get the state to recognize that the disorder existed among Black people. As you noted quite well, that because of that, there was, of course, the suit against the state that, and I'm glad to hear that it's resolved in a positive way. Later on, of course, when I was in D.C., and I think Dr. Walks remembered that I was the president of mental health, the DC chapter of Mental Health America, and our main point was, of course, to focus on autism, and we're working with Autism Speaks, as you said, make them culturally relevant. One point that I think the group should know was that there have been many active attempts, and I was involved in terms of looking at the genetics of autism, which we found, and I did a widely cited study showing that autism, of course, isn't a single gene disease, but there's a series of rare but powerful risk genes that cut across between autism, antisocial behavior, attentional deficit disorder, and perhaps a little bit of schizophrenia as well. So the chance we're not going to find a single gene for autism is really the complexity of genes that interacts in complex ways. And the other point is that we've also been involved in clinical trials to try to develop some treatments that work. And the good news in addition to the early behavioral interventions, which you discussed, have been extremely effective, but also we now have medications that don't just
Yes.
zonk people out, but actually
Yes.
maintain their cognitive functioning.
Yes.
And interestingly enough, some agents that have been found to be effective with autism, we've also begun to use them with negative symptoms of schizophrenia.
Thank you, Dr. Lawson.
Thank you.
Judy Maxey has a hand up. Dr. Maxey?
Please recognize her.
Hi, everybody. Thank you for this
Hi.
topic. I worked for many years in the field of people with disabilities and have some family members have been diagnosed with various things as well. But my biggest concern has always been, and I still find it in the work that I do in the community here in South Florida, and people that I talk to from other places, is that families who speak to professionals about the concerns they have for their child are told to wait. And it just infuriates me. Why are you waiting? And I tell a lot of parents, if they will not follow through with making a referral for you to get the services that you need, find another person. They work for you. And it happens all the time. And one of the things I try to help families understand is don't worry about labels. Get the services that your children need. The labels are the opening to the door that you need for the services. It is better to do that than to worry about what's going to happen down the line and that kind of thing. And so one of the biggest things that can happen, I see all the time for many years, but unfortunately it still happens, is that families are afraid to speak up for themselves. We have to continue to help them be advocates for their children no matter what, and not to take no for an answer, and to make sure you do your research and make sure that you are asking the questions and getting the answers that you require to have to advocate for your child. But also, in addition, I thank you so much for your presentation, Dr. Pinnock, is that, just staying on top of it. And I think that's the biggest thing that I know that I have been able to impress upon a lot of families is don't wait and get somebody to help you through the process. Hold your hand, go to the doctors with you, or give you a brainstorming session with what things to ask. But whatever you do, don't let anybody tell you to wait on getting the services and supports that you need for your child.
Thank you so
You
much.
said it better, ma'am. Thank you.
Before we go to final comments, I'd just like to give Dr. Pinnock's boss a chance to make a comment. Then we'll go for final comments.
Thank you very much. And Dr. Pinnock, thank you for doing a great presentation. And I like what the last speaker said. Most important thing that we can do for our children is identify them as when they have an issue and make sure that they receive the services that they're entitled to. And it's really not that easy to do, because you really do, given the nature of our community, you as a physician, you find yourself having to do a lot of advocacy in terms of working with them. You just can't say to them, this is what your child has, and then that's it. And then that's it. You really have to go beyond that. And that can be extremely difficult, because I know most pediatricians have very, very busy practices at this particular point. Most family medicine people who take care of not only children, but adults. It's often very difficult in family medicine clinics for us to get them to address, when you're dealing with hypertension, diabetes, et cetera, and to actually advocate for children and do things like developmental assessment. But there's a whole set of entitlements that these families have. And if you can get them this is one instance in which getting them into a system as early as possible, as Dr. Pinnock said, makes a lot of difference, because then they are mandated often by, as Dr. Lawson will tell you, by law, to provide level of services that these families need, and that can make a major difference in the outcome for their children. Thank you.
Thank you so much, Dr. X. Bean, the Chief of Pediatrics at Meharry Medical School. For final words, Dr. Pinnock, this was an excellent talk, and we learned so much, and we'd like to have you come back at some point. But would you give us final words before we go to our co-moderators?
Keep doing what you're doing. It's always been, I've been a pediatrician, a developmental pediatrician, but still the little old ladies at church would always ask me about their medications and their diagnosis because they trusted me. And I think most of the providers on this call are long trusted providers. And if it's not your area, just help the parents get to the areas. But we've got to fight for this because our kids are really being hurt. They are. It's no question. So thank you again for the opportunity to talk to you.
Thank you. Final words, Dr. Hines.
I just want to thank you, Dr. Pinnock, for this presentation. As a parent, I'm going to make these comments as my parent, with my parent hat on. As a parent of two neurodiverse children, I can absolutely relate to many of the struggles that you identified in your speech, be it the 15, 18th month wait times for appointments or seeing 5 or 6 different providers, having to, navigate the system yourself because people keep telling you, it's probably just give it time. It's just a boy. That's just life. So I appreciate you bringing these points and discussions to the forefront so that we can continue to make sure, if it's not feeling right, that maybe there really isn't something, and having to keep pressing for an answer till you get an answer. It's difficult, and I appreciate the empathetic way that you presented that.
Thank you. Dr. Ivan.
Dr. Pinnock, thank you. And I want to comment on the bravery of Dr. Hines and other parents to let people know that I need help, that there should be something out here for my child. And then I just want to say that as just people, when we see a child that we think may not respond the way we think they should when we say hello, or keep reaching out to children. When you go to church, don't only talk to the kids who can't wait to talk to you, but just help to normalize the environment for children who may act different, walk different, talk different. Have an open heart for the diversity of young people and let them know that it's okay to be who they are. Because sometimes by reaching out to that child, you help them be able to reach out. So all the smart professional big boys and big girls that know all the good stuff, it's okay to just be a regular human being and reach out to young people and let them know that they're important. And last point is, thank you, Dr. Pinnock. Thank you, Dr. Exelana Bean, because my nephew, Ian Peace, went to Meharry School of Medicine, and he graduated and did very, very well. And he is now a young man out there making his way in the world as a caring physician. So thank y'all.
Thank you, Dr. Barbara Neighbor-Stephens.
Well, like everybody else, I am just extremely grateful that you took the time to share your wisdom with us. And I hope our audience and their networks will take up the charge. As you were talking, I was thinking, in how many ways can we hold our society accountable? And I kept thinking about, now this is too late because Head Start at the earliest is 3, in most places it's 4. That's too late. But what kind of interventions can we make sure are in place at every point that touches a child's life, whether it be WIC, their healthcare provider, wherever they're going, to make sure that the families receive the information that they need so they can access the resources that they need. One final word. Another thought I had with my sorority chapter is having a Mommy Dearest baby festival in April. And we've been focusing on the maternal experience and trying to improve that, as well as care of the children. But I'm getting ready to call that chair right now when we get off and tell her we're going to have to introduce child development. the whole gamut into
Mm.
this festival, because this is a way of spreading the word. Thank you so much. Like
Can
you.
I say one more thing?
Mhm.
You are so right, y'all. The incidents, I didn't say this when Dr. Maxey asked for more definition. The incidents in autism last year was 1 in 36. Looks like this year, the CDC numbers are going to be 1 in 32. So we got work to do. We got work to do.
Thank you. And as my final word, first of all, I'm very grateful for this information about early intervention and how important that is. And we know that not only now for this, but we know for high blood pressure, cardiovascular disease, everything. The early bird gets the worm, and getting that worm is so important with our children and infants. I want to remind everybody that next week, the 25th, we have Dr. Brian Stone, who's going to talk about prostate cancer, which has affected our Secretary of Defense. And for those of you who are British citizens, the King of Britain may have some problem like that. And Black men have a high incidence of this. And the following week, we're going to have Dr. Bron Bailey, who's the chief of psychiatry at Louisiana State University. And we have others coming forward. So we thank you so much for your attention today. Have a great, great day. Thank you, Simon, so much.
Good day, everyone.
Bye.
Bye-bye.